to AETCM, the emergency medicine channel. Today let us discuss about an important anemia, that is sickle cell anemia. It's a hemolytic anemia. It's a congenital type of hemolytic anemia. Many family members can be involved in this type of anemia. So we will be discussing sickle cell anemia, clinical features, and how to manage this problem, or what are the major issues in emergency room because of sickle cell anemia and how to manage these issues in emergency room. So it's an abnormal hemoglobin polymerization. When we discuss about various type of hemolytic anemia, we know that it can be a problem inside the cell. That can be an enzyme defect, hemoglobin defect, or membrane defect of the hemoglobin. In that, the most important thing is the hemoglobin defects. Sickle cell anemia and thalassemia both will produce abnormal hemoglobins. So here in the hemoglobin there will be substitution of valine for glutamic acid at 6th position of the beta globulin polypeptide chains. And if homozygote produces only HbS, that is SS, it is sickle cell disease. Both sides from the parents, if you are getting sickle gene, then it will produce sickle cell disease. Patient will have all features of sickle cell disease. And heterozygotes produces both HbA and HbS. That means one from the father, one from the mother, that produce AS, that is normal gene with abnormal gene. That cannot produce a disease, it can produce only trait. That means that we will see afterwards. So sickle cell disease means they have two abnormal genes. Sickle cell trait will have only abnormal gene that produces only trait. They are carriers, they cannot develop disease. Now, when you have sickle cell anemia, normally the RBCs are very flexible and they are round shaped, and they can move through the smaller blood vessels easily because they are flexible and because of their shape. Sometimes it is round shape or dumbbell shape. But whereas in sickle cell anemia, the shape of the RBC will be altered. It will become like a sickle. Both sides are very sharp. It can go and obstruct any artery, especially smaller arteries. So when the hemoglobin is deoxygenated, it becomes sickle shaped cells and it can block the arteries. Sometimes the problem can be irreversible. Sometimes the problem will be reversible, and if you give oxygen and adequate fluids, this can be reversible. Sometimes it will become irreversible and RBCs are permanently damaged, so it can block the peripheral circulation or internal circulation and also produces severe hemolysis. Now many patients who is having sickle cell anemia, that is SS variant, they can have severe hemolytic anemia. So because of the abnormal shape of the RBCs, it can be destructed in the circulation or in the spleen. So patient can have anemia, and this anemia can be sometimes aggravated due to low erythropoietin levels like kidney failure, because many of these patients can have chronic kidney obstruction and kidney failure can be there, or because of iron deficiency or folic acid deficiency anemia. And many of these sickle cells, abnormal cells, normally the size and shape of the RBC, they are like rounded or dumbbell shaped. When there is an abnormal RBC, that will be destructed in the circulation. So they can have hemolytic anemia. Some patients can have iron deficiency, B12 deficiency, and folic acid deficiency is very, very common because of rapid destruction of RBCs. Folic acid will be utilized for the production and there will be acute shortage of folic acid. So that also can produce anemia. Sometimes any infection, fever, all these things can aggravate the hemolysis and it can produce more sickling and more destruction. That also produces extra anemic features. Patient who is having severe dehydration also can develop severe hemolysis. So many conditions in sickle cell anemia can aggravate the anemia. Otherwise, most of the patients without any major issues, you can see the hemoglobin will be fixed somewhere around 7, 8 or 9. They have mild to moderate anemia, but severe anemia occurs when there is a additional problem. Now, we will see what is the why the patient come to emergency room in sickle cell anemia. We have already seen that sickle cell anemia means the shape of the RBCs are completely changed. They are like sickles, and both sides are very sharp. They can go and obstruct any artery, and it can produce infarction of any organ in our system. So, sickle cell crisis means there are different types of crisis. One of the major crises is infarction crisis. It will be very painful because it is a vaso-occlusive crisis, and it can obstruct any organs in our body. It can obstruct coronary circulation. Patient can have myocardial infarction, cerebral circulation. Patient can have stroke, splenic circulation. You can have splenic infarct, liver circulation. Patient can have liver injury. So many areas it can block the circulation, and it can produce associated features. So patient can have severe pain, and it can be triggered by dehydration, fever, stress, alcohol, menstrual periods, pregnancy, cold weather. All these things can aggravate this problem. The problem here is the sickle shaped RBCs obstructing the microcirculation. Wherever it is, like brain, it can produce like a stroke-like features, myocardial infarction or ischemic heart disease. Like that, various presentation can be there. You can see the problem here. Sickle cells produced infarction of the arteries, and it can produce various clinical features like CVA, retinopathy, vascular necrosis of the shoulder, and other bone vascular necrosis, pain, muscle pain, abdominal pain. All these things can be there, and these abnormal RBCs also can be destructed. That is called as hemolysis. So same time patient can have infarction crisis, and patient can have associated hemolysis also. Some patients can come with severe chest pain. It can be due to pulmonary infarct, or it can be due to myocardial infarct. It can be due to pleuritis. So many abnormal problem can be there because of this infarction crisis. So infarction crisis, various examples are given in this slide: hand-foot syndrome, mesenteric ischemia, surgical abdomen, cerebral infarction and stroke, renal necrosis, renal failure. Priapism is one of the important problem in males. Painful erection because of the penile venous outflow tract, that is very important. Leg ulcers, especially chronic leg ulcers, are very common in this type of conditions. Acute chest syndrome can be due to pulmonary infarction or pulmonary hypertension due to chronic cor pulmonale. Like that, we can have chest pain. Recurrent splenic infarct, some patients develop autosplenectomy. That means recurrent infarcts in the spleen. The areas in the spleen, multiple areas in the spleen will be initially destroyed. Ultimately, spleen itself will be destroyed. This is called as autosplenectomy. Venous thromboembolism also can be there in infarction crisis. Now, acute chest syndrome, we already seen that patient can have pulmonary embolism, pulmonary infarction, pulmonary hypertension, or myocardial infarction itself can present with acute chest syndromes. Now, bone problems are very important. This is like there are two important problems you can see. One is the changes due to exaggerated production of RBCs. So the mainly the bones can be enlarged. That may lead to tower skull, bossing of the forehead, fish mouth deformity of the vertebrae. These are some important changes you can see in the patients who is having increased production of RBC from the bone marrow. Another important problem is avascular necrosis of the bones. Avascular necrosis means blood vessels to the bone that is blocked. So every bone will have blood supply. If that is blocked, bone will develop avascular necrosis. So that can lead to sometimes bone infarct, loss of trabeculae. Patient can have fractures. So many abnormal problems can be there due to avascular necrosis, and sometimes patient can develop osteomyelitis. That means infarction of the bone, death of the bone tissue leading to the loss of bone tissue. Ultimately, it will lead to osteomyelitis. Now, this is bowsing of the forehead. You can see the frontal bone is projected out. Then avascular necrosis of the major bone heads, lower limb and femur, humerus, all these things you can get avascular necrosis of the bone, especially when there is a neck of the major bones are involved, that can lead to acute fractures. Next one is hemolytic crisis and sequestration crisis. So, there are two important things. One is intravascular hemolysis occurs because of these abnormal cells can be picked up by our immune system as a foreign body, and that can be destroyed in our circulation. Second problem is when there is a large spleen, especially many patients with hemolytic anemia initially can have a large spleen, and there will be sequestration of these abnormal cells into the spleen, and there it will be destroyed. Whatever it is, peripheral destruction of RBCs sometimes increases. Bone marrow may not be able to produce or compensate for this destruction, so the patient can go to severe anemia. So, this is called as hemolytic crisis or sequestration crisis. Sequestration mainly occurs in the spleen, and sometimes because of the chronic obstruction in the spleen, a patient can develop autosplenectomy also. Many patients who is having chronic hemolytic anemia with elevated indirect hyperbilirubinemia can have cholelithiasis. They can develop stones in the gallbladder because of the elevated bilirubin for a long period. You can see the hemolytic crisis here. RBCs are lysed continuously. When there is sickling formation, that hemolysis, the number of hemolysis will increase because these are abnormal cells in the circulation and the spleen. So, that can produce hemolysis. If the patient develops this type of hemolysis inside the spleen, we can call it a sequestration crisis. Now, next one is aplastic crisis. That is also very important because sometimes bone marrow will not be able to produce or compensate for the peripheral destruction. One of the major factor for this is parvovirus B19. So, any patient who is having severe anemia in most of the conditions where there is immunocompromisation or conditions like chronic hemolytic anemia, one of the major cause for this is aplastic crisis, that is due to parvovirus B19. There are other causes also for destruction, many infections, bone marrow infections or infiltration of bone marrow. All these things also can present with aplastic crisis, but most important thing is parvovirus B19 infection. Now, sickle cell trait, it's usually asymptomatic. In sickle cell trait, the usual pattern is found more than 50% adult hemoglobin, 35 to 45 hemoglobin S, that is sickling type of hemoglobin, and less than 2% hemoglobin fetal. So, HbF is 2% and adult hemoglobin more than 50%. So, they may not develop much clinical finding like sickle cell disease, but they can definitely transmit the disease from mother or father to the child. Sickle cell beta thalassemia is associated thalassemia with sickle cell disease. Now, sickle cell trait is usually asymptomatic. We have seen the previous slide. It is mostly asymptomatic. Sometimes patient can develop minimal anemia. In sickle cell trait, usual pattern is to find more than 50% hemoglobin A, that is adult hemoglobin. You can see the family tree here. So, from parents, the disease is coming to out of 4, only 1 or 25% is developing sickle cell disease. 50% are carriers, they can carry the disease to next generation. 25% is not having any disease. There is no gender differentiation for this type of diseases. Both male and female patients can develop sickle cell disease, but somehow the morbidity and mortality is very high in female patients, but there is no gender differentiation in sickle cell disease or trait. Now, whenever we have hemolytic anemia, we always try to do one Coombs test. Coombs test will be negative here because it's not an immune mediated hemolysis. So, next one we can do a hemoglobin electrophoresis. You can see the hemoglobin electrophoresis in this patient who is having sickle cell disease. Hemoglobin S will be very high, and to compensate that problem, hemoglobin F will be increased, that is fetal hemoglobin. Hemoglobin adult is very low. So, HbA is low, HbS is very high, HbF try to compensate that for the loss of HbA. So, that is a problem in hemoglobin electrophoresis. HbF has higher oxygen affinity than adult hemoglobin, and if you try to increase the HbF levels, we can possibly treat or manage the patient who is having HbS or sickle cell disease. So, in sickle cell disease, HbS is very high, that is an abnormal hemoglobin, HbA is very low, and HbF is trying to compensate the loss of HbA. If we try to increase the HbF with a medicine, we can probably counter the problem of hemoglobin S or sickle cell disease. That is the treatment plan. Now, we can manage the patient. So, whenever there is a vaso-occlusive crisis, most of the patient come to emergency room with severe abdominal pain or chest pain, acute chest syndrome you have seen, or stroke or myocardial infarction. Death of these patients can mainly occur due to stroke or myocardial infarction. So, we have to be very careful whenever a sickle cell disease patient come to emergency room with abdominal pain, chest pain, myocardial infarction, stroke. All these things can be due to the crisis. That means it's an infarction crisis. So, aggressive hydration is very, very important, because we know that whenever these blood vessels are clogged with sickle type of RBCs, if you give fluids, it will be diluted. So, you can increase the flow with increased fluids. That is very important. So, hydration is very important. Second thing is oxygen. So, whenever you have hypoxemia, the sickling occurs very fast, and if you don't treat that, it will become irreversible. So, as soon as possible, when the patient come to emergency room with the infarction crisis, start fluids, then give oxygen. Okay. Second thing is so fluid and oxygen. Third thing is morphine. So, we have to give morphine for pain relief. Then antibiotics if you are suspecting an infection, like patient who is having chest disease, like somebody is having a chest infection, they can have sickling, extra sickling, or can occur due to the infection or due to the hypoxemia. So, we have to treat the hypoxemia, and we have to also treat the infection part. So, we have to start antibiotic. Exchange transfusions also can help in many patients, because if we remove full blood and transfuse fresh blood, you can avoid probably the sickling. So, exchange transfusions are very good option in emergency room. Blood transfusion advised in patients who is having severe anemia. Exchange transfusion can benefit patients with neurological symptoms, chest syndrome, and severe painful crisis. And longer transfusions can sometimes lead to iron overload. That also we have to be very careful. So, you can try to maintain the hemoglobin level just about 10. That is more than enough. No need to keep it very high. So, just about 10 will be more than enough in most of the patients. Now, hydroxyurea is one drug which can increase the HbF levels that we have seen in the previous slides. If you improve the HbF, you can counter the overproduction of HbS. So, 10 to 30 milligram per kg per day can be given, or other drug like 5-azacitidine 0.15 to 0.30 mg per kg 5 days in a week for 2 weeks. So, that can be started. Hydroxyurea increases the HbF levels. So, remember, it increases good hemoglobin which has got more affinity for oxygen. So, that can be increased. Other drugs like crizanlizumab, L-glutamine, and voxelotor. So these are the newer drugs can be started in patients to reduce the incidence of vaso-occlusive crisis, and voxelotor was also beneficial in reducing anemia and hemolysis in sickle cell patients. So these drugs also can be tried. So these are the common drugs which can be used in sickle cell disease, like L-glutamine, voxelotor, crisanzimab. So these drugs can be given. Doses are 5 gram, 15 gram, voxelotor 1500 milligram, other drug is 5 milligram per kg body weight. So you can refer this chart afterwards. Other management protocols are bone marrow transplantation can be done in children, because we know that the production of the RBC itself is abnormal, so bone marrow transplantation can be tried. Agents blocking RBC dehydration and vascular adhesion, we can start as clotrimazole and magnesium. All patients who is having any type of hemolytic anemia, we have to start folic acid 5 milligram per day, because hemolytic anemia including sickle cell anemia can produce severe hemolysis and increased production of RBC from the bone marrow, and the folic acid levels in our body is very low. It may not be able to contribute in production of RBC if the levels are very low. So whenever possible we have to try to replace folic acids because of this high marrow production. So give more folic acid so that the production will not be reduced. So we have to take care that iron should be there properly, folic acid should be there properly, B12 should be there properly to produce the bone marrow. So otherwise it can go to marrow failure. And parvovirus B19 also we should consider when there is a problem in the bone marrow production. Patients who is having infection, suspected infection due to pneumococcal infection, like a patient who is having splenectomy, like who is undergoing splenectomy or autosplenectomy, like we have seen that previously repeated splenic infarct can produce autosplenectomy. We have to give all these patients pneumococcal vaccination, prophylactic vaccination should be given to all patients, and some patients may require penicillin prophylaxis to prevent pneumococcal infection. So we have discussed about one of the important hemolytic anemia, which is very common in our country, but these diseases are seen only in some pockets, not seen everywhere. So some areas it is very common. These patients can come to emergency room. Most of these patients are asymptomatic, they are well maintained most of the time, but they come to emergency room with acute infarction crisis like myocardial infarction, stroke, ischemic colitis, like that. They come with severe pain to the emergency room. Do not forget to give fluids, start oxygen. Pain management is very important. We cannot do more than that in emergency room, because the main problem in this is sequestration, blockage of the arteries, hemolysis. We can only treat the obstructive part from the emergency room. To prevent obstruction, we have to avoid situation like patient should not be dehydrated, patient should not develop hypoxemia, infection should be avoided. All these things are very important, but once the patient develop all these things, try to give more fluids, try to give oxygen, and pain management is very important. Make sure that patient is taking hydroxyurea and other drugs we have discussed in adequate dose. Thank you.